Hey, anesthesia nerds, what's going on? It's Tasha McNerney, and I just wanted to chat with you really quickly about something that's come up a couple times on the anesthesia nerds, and I just wanted kind of to walk you through when we are deciding if we're going to start a patient on a blood pressure support medication, right? And I'm looking at what I have on the shelf, and maybe I have dopamine on one shelf and I have dobutamine on the other. How do I decide which one I might use? So we're going to break this down really quickly, and I'll let you guys know kind of what I look for with these two drugs. So hopefully you guys can see this, but we'll remember from our blood pressure equation, right, that our blood pressure is going to be reliant on our systemic vascular resistance and our cardiac output. So our cardiac output is made up of what? Our heart rate and our stroke volume. That's why I say when we are looking at whether or not we are going to, or how we're going to treat a low blood pressure, we first want to figure out what is the cause of that low blood pressure. Do we think that it is mainly heart rate? Do we need to give it a little bit of a anticholinergic to speed it up? Do we think it's volume, right? If the patient is losing a mass amount of volume, then maybe we need to just replace the volume. Or is there a systemic vascular resistance issue, right? So our vessels, are they dilated because of drugs like propofol or acepromazine or inhalant anesthetics? Do they need a little squeeze on them to increase that blood pressure? Do we need to start some of these drugs for support? So dopamine gonna go to different receptors. That's why some people say that it's kind of a dirty drug. It goes to a bunch of different receptors, has some effects. Whereas dobutamine is really going to focus in on that beta-1 receptor. And what's that beta-1 receptor responsible for? Increasing our contractility. So this lovely diagram here, this is kind of what I think of. When we increase that contractility, if we think about the heart, we're giving it a little more of a squeeze. We're just putting a little oomph behind it, right? So that beta-1 receptor with the dobutamine, this is how I remember it, beta with our dobutamine, two B's in there, right? So we're going to increase that contractility. So this is for patients, right, that maybe have mitral valve disease or DCM or something like that, where they actually do need a little bit more contractility. Or again, in the case of like mitral valve disease, we actually want to avoid that peripheral vasoconstriction because we don't want stuff backing up then into the heart and increasing that chance of regurgitation. So if I'm looking at a patient in front of me, if they have cardiac disease, usually, again, it's a boxer in front of me, maybe I am going to start them on dobutamine because I want to focus on bringing up that contractility. However, for our basic patients under anesthesia, I usually am going to start with dopamine, a little bit of increase in contractility, and a little bit of vasoconstriction. Now remember, we don't want to start either one of these drugs if we have a patient that is behind on fluids, right? Because by starting these drugs, we want to make sure that this patient is as normovolemic as possible, right? Some things to note as well. If you have a patient on dobutamine or you're starting dobutamine, remember, it is going to be less effective if you have a vasodilatory shock patient, right? So if we have a patient come in, they're just in septic shock, this is probably not the drug that we are going to be reaching for. Remember, I'm kind of talking about in the context of under anesthesia here. With dopamine, something to keep in mind is that you have the potential for arrhythmias, not only tachyarrhythmias, but also bradyarrhythmias. Why? Because as we get into those higher doses and we have more alpha-1 effects and more vasoconstriction, just like with your dexmedetomidine, as you have more vasoconstriction, right? We take our vessel from this down to this. Now we send a message to the heart that we can slow that rate down. So we get a decrease in our heart rate. So sometimes we get tachyarrhythmias or bradyarrhythmias. So remember, dopamine is going to give a boost to a lot of things, right? Dopamine is going to kind of go everywhere and give a little boost to contractility, a boost to systemic vascular resistance, whereas dobutamine is going to really focus in on the beta receptors of the heart and just kind of boost the contractility there. So either one chef's choice here, but for the most part, you're choosing dobutamine specifically if you have a patient that has some kind of cardiac disease. All right, hope this was helpful. Bye.